Yes, ma'am, we are live now.
Yeah, Deepa.
Okay. Good evening, respected senior members of ISPAE, faculty for today's program, senior pediatricians and friends. We welcome you to another exciting session of ISPAE ACES program, that's Academic Clinical Education Series program. This flagship session was started 1 year ago by our ISPAE president, Dr. Shaila ma'am, and we have been successfully conducting this ACES program over the past 1 year, involving many national and international speakers. Dr. Shaila ma'am, the president of ISPAE, doesn't need any introduction to this group, and I welcome ma'am to start the proceedings.
Thank you, Dr. Deepa. Good evening, everybody. First of all, I would like to, because this is the first program of 2022, wishing you all a happy new year, and hopefully we won't see any more COVID waves. Hopefully, let's all end the third COVID wave in January or February or March of this year. Hopefully, we will all try and meet physically so that it will be much more helpful, nice, encouraging, enthusiastic. And today I have a great pleasure because we have finished 12 successful meetings, which were been very useful from fellows, students, general practitioners, and even senior consultants. They have been very useful. Today we have a very interesting, very common topic, thyroid disorders in children. And for this, we have Dr. Susan Rose and Dr. Andrew. Dr. Susan Rose, she is the from she's Professor Emeritus from Cincinnati Children's Hospital. She has major role in preparing the USA guidelines for congenital hypothyroidism of 2006, and we are here to listen to the synopsis of 2022 guidelines also, which are not published. Welcome you, Dr. Susan Rose. And we have Dr. Andrew. I think we have been always reading articles of Dr. Andrew, but now it is very nice that we are able to meet him physically. He's the director of the Thyroid Center, Division of Endocrinology and Diabetes, Children's Hospital, Philadelphia. And he has have many publications, and he's been a great reviewer for many articles and various journals. We welcome you, Dr. Andrew. We are very excited to hear your talk. Without Dr. Sudhir and Dr. Rekha, I think our meeting would be very not fruitful, because Dr. Sudhir and Dr. Rekha, who are trainees, have agreed to present the case. And these two cases will be moderated by Dr. Anil Bansali, who again doesn't require any introduction. He's the professor and head department of endocrinology, PGIMR, and he's been my senior and also my teacher when I was doing my DM in PGI Chandigarh. And he has got more than 500 publications and many citations. And very proud to tell that he has received Dr. PC Roy Awardee, and he has been former president of ESI and Punjab RSSDI. And he has been author of clinical rounds in endocrinology. And we all, his students, remember the way he taught, the way he approached the clinical scenarios. It is all stuck in our head. So it's been, and it's so good. So I'm sure you will see him in next half an hour to 1 hour, how he has been a very good teacher for us. Welcome you, Dr. Anil Bansali.
Thank you, Shaila, for very kind words.
And Dr. Vijay Kumar, he's professor of pediatrics and pediatric endocrinologist from Kerala. And this year he's also IAP president of Kerala, and he is a state coordinator for newborn screening of congenital hypothyroidism. He is the first person in India who has got free congenital hypothyroidism screening in Kerala, which we have been trying, but we have still not been able to achieve it. And he's also state nodal officer of MITAI program, that is a type 1 diabetes program, where children with type 1 are given free insulin glucometer and free consultations. He's been past president, secretary of, past state secretary of ISPAE. He's currently president of IAP Kerala, and he's been editor IAP Kerala State Journal, pediatric companion, and he's ever smiling, ever cooperative, and a very good teacher. Welcome, Dr. Vijay Kumar.
Thank you, Sheila Madam, for those nice words. Thank you.
So we will have our first, Dr. Sudhir is presenting the first case, right? So Dr. Sudhir's CV slide, please. Dr. Sudhir is a second year PG student from PG Department of Pediatrics, MKCG Medical College and Hospital, Berhampur. His mentor is Dr. Narendra Behra, Associate Professor Dr. Bharti Das. It's very nice. Even our pediatric PGs are presenting case here. I congratulate you, Dr. Sudhir. Welcome to our ACES meeting. And for the first case, Dr. Anil Bansali is the moderator. Thank you. So we can go ahead and we can start the program. You can start sharing, Dr. Sudhir.
Yeah, thank you, Sheila.
Thank you, sir.
Yes. Sudhir, yes, you can start now.
Yes, sir. Good evening, all respected faculties, organizing team ISPAE, and other faculties, seniors, juniors who have joined this section to make it fruitful. Myself, Dr. Sudhir Ranjan Senapati, a second year postgraduate student from MKCG Medical College, Berhampur, presenting before you a case of our SNCU neonatal hyperthyroidism with maternal thyroid dysfunction, the double trouble, and will be moderated by Professor Dr. Anil Bansali sir, Endocrinology Department, PGIMR Chandigarh, and has been guided by Associate Professor Dr. Bharati Das ma'am from our Medical College, Odisha. The learning objective of this session, when we are evaluating, it is extremely important to obtain an antenatal history along with detailed maternal thyroid status. Thyroid function test along with thyroid function test along with thyroid function test along with thyroid hormone and antibody screening carried out in the first month of first few weeks of life should be repeated on 5 to 7 days of life. Beside the classical clinical symptoms of thyrotoxicosis, that is tachycardia, tachypnea, hyperexcitability, feeding difficulties, and poor weight gain, eyelid retraction, periorbital edema, and signs of supraventricular tachycardia, pulmonary arterial hypertension, systemic hypertension, congestive heart failure should also raise the high degree of suspicion of hyperthyroidism and should need active intervention at the earliest. Neonatal hyperthyroidism should be treated promptly in team approach by obstetrician, pediatrician, endocrinologist, cardiologist with regular follow-up and to avoid future complications. Case description: a newborn of 33-week gestational age, female, born of LSCS, weighing of 1.9 kg, born to a 24-year-old primary on 9th June 2021 at 9:30 a.m. referred to us from a private hospital with referral slip showing complaint of respiratory distress for 1 day, tachycardia for 6 hours. Patient was under treatment for low birth weight in some private hospital, thus then referred here. The informant being father who was reliable. The pertinent antenatal history to this case is patient was the baby was born of non-consanguineous marriage and the mother married since 3 years and was on infertility treatment for 3 years. The baby delivered of LSS delivery, the indication being preterm premature rupture of membrane and primary infertility. The liquor was clear and adequate, non-foul smelling. Baby was tried immediately after birth. The history of then coming to present illness and course during hospitalization. The baby was managed in a private hospital in the line of preterm and low birth weight with IV fluid and injectable antibiotics, developed tachycardia, tachypnea on day 5 of life, referred to us. On examination, the baby was very sick, pale, tachypneic, peripheral cyanosis, and cutaneous mottling. The temperature was 38 degrees centigrade. SpO2 was 84% on room air, 94% with 1 liter of oxygen. Respiratory rate was 88 per minute. Heart rate was 250 to 300 beats per minute. So the patient was kept NPO, injection antibiotic, and IV fluid was started. And the bedside ECG suggestive of supraventricular tachycardia. So ISPAE over the face was applied. Carotid massage was given, having no results. So injection adenosine was started. The heart rate came down below 190, but again went up greater than 200. The baby could not be shifted to NICU, and the patient deteriorated. This is the ECG. You can very well see there is a narrow QRS complexes with heart rate of more than 300 beats per minute, which suggestive of supraventricular tachycardia. On the next day, the baby also developed features of hypotension. Capillary refilling time was greater than 3 seconds. NIBP was 44 by 30 millimeter of mercury. Heart rate was 170, and liver was not palpable. So injection dobutamine was started at the rate 10 microgram per kg per minute. Patient develops features of sepsis with PETG with platelet count of 10,000 microliter. So antibiotic was upgraded to injection Merobanco, and RDP was transfused. On repeat ECG, you can very well see the sinus rhythm pattern and heart rate of 150 beats per minute, right axis deviation, and the narrow low QRS voltage QRS and a prominent PUF, which was suggestive of myocarditis. So 2D echo was planned. The 2D echo revealed right atrial enlargement, moderate tricuspid regurgitation, moderate pulmonary hypertension with normal biventricular function. So with no structural heart lesion. So due to combat moderate pulmonary arterial hypertension, sildenafil was started at the rate 2 mg per kg per day, 20 years. With normal biventricular function, so dobutamine was tapered and stopped, and the repeat 2D echo was planned for after 2 weeks. The baby was developed abnormal body movement and staring gaze. So, to rule out seizure, we have done RBS, which was normal, and VBG shows calcium, which was also normal. So, loading 1 Gardner was given, which was confused with the anxious look, irritability, perspiration, poor weight gain, wide open eyes, moist and warm and moist skin, and associated with tachycardia, tachypnea of heart rate 200 beats per minute and NIBP of 90 by 60 millimeter of mercury. So gave the clinical suspicion of neonatal hyperthyroidism. On interrogation with the father, revealed some thyroid issues in the mother, which was not exactly defined. Moreover, the mother's antenatal medical records were kept at the native place. Later, the maternal record revealed hypothyroidism with anti-TPO antibodies titer raised 2 years prior to pregnancy, which has been found while evaluating for primary infertility. The patient was on levothyroxine. The mother was on levothyroxine supplementation of 120 microgram daily, which has been tapered to 100 microgram in the mid-trimester as per the mother. So TFT of the baby and mother was advised to know the present status. Meanwhile, due to persistent tachycardia and systemic hypertension, injection ESMOL was planned, but due to unavailability, propranolol was started, and later switched to ESMOL. After 48 hours, there is no much change in blood pressure and heart rate. So, meantime, the TFT report came, which shows you can very well see the T3, T4, and TSH and interpretation as hyperthyroidism, as the TSH is very low as per the reference interval, and T4 is very high as per the reference interval. On consultation with the pediatric endocrinologist, anti-thyroid treatment, that is carbimazole are there at 0.5 milligram per kg per day, and propranolol was started. Although the patient was having hemodynamic instability, we could not start glucose iodine, which was not available locally. Gradually, heart rate and BP was under control. 2D echo after 10 days shows right atrial enlargement with mild pulmonary arterial hypertension and normal biventricular function. After starting of the therapy, regular follow-up, the patient is now doing well, gaining weight properly, and 2D echo normal after follow-up study. You can very well see the lab reports of platelet 10,000, WBC 32,560, neutrophil of DCF neutrophil 83, which is features of sepsis. So one RDB was given, and other serum profile being normal, GBG also normal at the time of seizure. Blood culture shows growth of staphylococcus with sensitivity to linezolid vancomycin, so it was upgraded. The early onset sepsis might be due to preterm pre-rupture membrane rupture of membrane. This is the maternal thyroid profile, which can be which was done 2 years prior to pregnancy in the month of June 2019, which shows there is a hypothyroidism, which was again confirmed by anti-TPO antibody with rising titer of greater than 1300 international unit per ml, which is confirmed. And on consultation with endocrinologist, the mother was on levothyroxine supplementation. After the delivery, we advise both the mother and baby's thyroid profile, which shows there is features of hyperthyroidism in the mother. So according to the endocrinologist, they have stopped levothyroxine supplementation and on regular follow-up as per the endocrinologist. Now coming to the baby's thyroid profile. The baby's thyroid profile was sent on day 14 due to unavoidable circumstances, like the baby presented to us on day 5 of life, and we have not initially we have not detected it as we have not suspected that it is a neonatal hyperthyroidism, as there are different clinical manifestations are being done. On day 14, the thyroid function test shows hyperthyroidism, neonatal hyperthyroidism. TSH is very low in comparison to the normal reference level, while the TSH T4 level is very high. So after consulting pediatric endocrinologist, tablet carbimazole and propranolol was started. After 6 weeks of treatment, you can very well appreciate that the patient has normal becoming euthyroid and was on follow-up by the pediatric endocrinologist. You can see the TSH receptor antibodies of rising titer even after 2 weeks of antithyroid treatment. If it had been done earlier, it might show very high titer. This is the baby showing the features of neonatal thyrotoxicosis before treatment of perspiration, wide staring gaze, wide angle papillary fissure, which are miraculously playing well after the treatment and doing well and adequately gaining the weight. The peculiarity of our case is mother being autoimmune hypothyroid with baby born with hyperthyroid is rare. Neonatal hyperthyroidism presenting as supraventricular tachycardia, pulmonary arterial hypertension, systemic hypertension is also rare, which is very few cases has been reported. In fact, having all the above features in a single neonatal hyperthyroidism is the rarest. And coming to neonatal hyperthyroidism, the neonatal hyperthyroidism, the etiology being maternal Graves' disease, which is the most common, or other causes comprising activating mutation of the stimulatory G protein in McCune-Albright syndrome, activating mutation of the TSH receptor. The clinical picture of neonatal hyperthyroidism being prematurity, intrauterine growth restriction, neonatal goiter, hyperthermia, feeding difficulty, poor weight gain, sympathetic symptoms like tachycardia, diaphoresis, hypertension, organomegaly, cholestasis, thrombocytopenia, hyperviscosity, eyelid retraction, staring, and periorbital edema, and arrhythmia, and congenital heart failure. The differential diagnosis includes neonatal sepsis, congenital heart disease like coarctation of aorta, and reversible pulmonary arterial hypertension, tachyarrhythmias like supraventricular tachycardia, inborn error of metabolism like congenital adrenal hyperesphagia, congenital viral infections, and narcotic withdrawal symptoms. The treatment of neonatal hyperthyroidism should be initiated at the onset of symptoms to avoid long-term and short-term complications like craniosynostosis and failure to thrive, developmental delay, and hyperactivity. The first-line treatment being methimazole or carbimazole in the dose of 0.5 milligram per kg per day in 2 or 3 doses. If the hyperthyroidism is associated with sympathetic hyperactivity, we can add a propranolol, which prevent the conversion of peripheral conversion of T4 to T3. If the hyperthyroidism is associated with hemodynamic instability, then potassium iodide in the form of Lugol's iodine can be added and prednisolone can be considered. Treatment of the neonatal hyperthyroidism should be monitored by clinical examination and measurement of TSH and T4 every 10 to 14 days and TSH receptor antibodies every 3 to 4 weeks. The treatment can be stopped when the TSH receptor antibody became undetectable. This is a algorithm showing how to manage a case of neonatal hyperthyroidism with maternal thyroid dysfunction. You can very well see this is a nicely described neonatal how to approach a case, which can be described in subsequent sessions. Then the reference being the Nelson Pediatrics of Pediatrics and others have a reference. Thank you.
Thank you. Okay.
Can you stop sharing?
Yeah. Thank you, Dr. Sudhir. And thank you for presenting this challenging case and nicely summarizing, because these are the very unusual cases which we even find in clinical practice. So this case had many peculiarities, in fact, which you have also highlighted. The first thing I think which you have highlighted was the maternal status. Normally, the neonatal hyperthyroidism is a manifestation of the maternal thyrotoxicosis or maternal hypothyroidism, and particularly when the mother is in a euthyroid Graves' disease, then there is a very high probability of having a fetal or neonatal hyperthyroidism because of the transplacental passage of the thyroid receptor stimulating antibodies. However, in this case, she had a hypothyroidism. And then later, I think if you see the last profile, just soon after delivery, because we had the profile, she was toxic. So this entity is a spectrum of the disease of an autoimmune thyroid disease, where from at one end you are having hypothyroidism, at the other end you are having a hyperthyroidism. It is just a critical balance between the presence of stimulating or blocking antibodies. So this woman initially had blocking antibodies, had a hypothyroidism. However, she had just prior to possibly 1 or 2 months prior to pregnancy, she had a more stimulating antibodies. That's why she also had some manifestation of toxicosis, and the neonate and the fetal and possibly the neonate also had a features of thyrotoxicosis. So this is not surprising. This entity is called as a fluctuating thyroid function. So you have a critical balance between the stimulating and blocking antibodies. However, this is usually rare. This usually we find a history in women with euthyroid Graves' disease who have a TSS receptor stimulating antibodies, and they do cross the placenta and causes the neonatal hyperthyroidism. So I think that was a very interesting in this case that we had presentation like this. And another predisposing factor for that, particularly those women who had a radioactive iodine ablation just prior to pregnancy and then conceived. So these women are more prone, possibly because of the slow release of these antibodies from the residual thyroid gland, as opposed to those who have undergone surgery. So that's another point, that the TRAB or residual antibodies are more likely to be present those who have been treated with radioactive iodine. Another point which you mentioned was that in this child, the manifestation usually happens soon after birth or within 1 or 2 weeks. But sometimes if the mother is supposed toxic and mother is treated with antithyroid drugs, then the manifestation of neonatal thyrotoxicosis or neonatal hyperthyroidism is also delayed. This is because a neomercazole, it crosses the placental barrier and inhibits the fetal thyroid. So the manifestations of a neonatal hyperthyroidism usually appears after 1 or 2 weeks later when the neomercazole is completely washed out. However, in this case, because the mother did not receive the neomercazole and the child presented at a 1 week with the respiratory distress, and you can also appreciate the child also has had a stare. And we'll have some discussion on a BRT later when we have a discussion, but I think the two salient points which this child has, one is this fluctuating thyroid function in the mother, and secondly, the early presentation of neonatal hyperthyroidism because of the directly stimulating antibody to the neonatal thyroid. I think if we have in a chat box, we have a lot of questions, and then we can have it.
There are questions in the chat.
Yeah. So Deepa, you can read and we can have a discussion on that.
Yes, sir. So one question by Dr. Divya is that could the case be a transient case of hyperthyroidism? If so, how to follow up this children?
Yeah, so it is okay. So it is more likely to be a transient hyperthyroidism in this patient or in this baby, mainly because the thyroid receptor or TSH receptor stimulating antibodies were present in a very high titer. So this usually lasts for say 12 weeks to 16 weeks, and after that it abates. So it's only a very transient requirement is transient need for the antithyroid drugs is there. Once the antibody titer goes away, the fetal thyroid is restored back to the normal function. However, if you find that the absolutely normal function in the mother and the child and the neonate is having a features of hyperthyroidism, then I think you should think the possibility of the other causes, which he mentioned as either as a activating mutation of the TSH receptor or as a part of the McCune-Albright syndrome where you have a post-receptor GNAS activation. So these possibilities should only be considered in a scenario when the TREB antibody is absent and the mother is not having any history of thyroid diseases. So it is more likely to stay in transient rather than going for a permanent hypothyroidism.
And can breastfeeding be allowed in this situation? That's another question.
Breastfeeding allowed.
Breastfeeding, yeah. So I think so the breastfeeding, because there's no issue in breastfeeding, the child can be continued with the breastfeeding. Yes, even in the pregnancy or even in the mother who is taking the antithyroid medications, the safer doses of a neomercazole, which allows the minimum secretion of the neomercazole in the breast milk, is doses up to 15 milligrams. So women who are receiving 10 to 15 milligrams of neomercazole, the secretion of the neomercazole into the breast milk is minimum, and it is unlikely to inhibit the neonatal hypothalamo-pituitary thyroid axis. So in this case, mother is definitely, yes, the mother will be treated with neomercazole. If the dose requirement is around 10 to 15 milligram, then can be safely breastfeeding can be done. The second point here is that the neomercazole can be taken after the 4 hours prior to the breastfeed or 4 hours after the breastfeed. That's another way the people have done that.
Which should guide the therapy, thyroid function or antibody levels?
Another question is by Dr. Anju Virmani, madam, is that should we use antibody levels to guide therapy for the or the TFT in this study?
Yeah, so I think the thyroid function is important, and anti-thyroid antibody, the TSH receptor stimulating antibody will definitely guide for the withdrawal of the drug. So first, the TFT should be normalized. That's one. And secondly, the antibody should be followed just to tell that the patient is likely to remain in remission or likely to remain the normal thyroid function. So I think I will say first TFT should be followed, and later on the TREP should be done to predict that the patient is unlikely to have a recurrence of a disease.
Sir, another question by Dr. Parvati is that is it common to have central hypothyroidism in babies born to grave mothers?
Fetal
And
thyroid
how long does
maternal
hypothyroidism last based on?
Okay, how do we treat this fetal thyroidoxicosis with maternal hypothyroidism? In case if diagnosed during gestation of around 30 weeks, fine. So how do we treat with the fetal thyroidoxicosis? So I think that what is the cause of the fetal thyroidoxicosis? So we presume that if the mother is having a positive TREB, means thyroid TSH receptor stimulating antibodies, the mother should not stay hypothyroid. But in that scenario, usually we talk of a block replacement therapy. The block replacement therapy is usually in a scenario you are using the neomercazole for treating the fetal hypothyroidism. And you are, because as you are treating, so the mother become hypothyroid, so you give a L-thyroxine for that. So the block replacement therapy is basically required for the fetal hypothyroidism and maternal hypothyroidism. Here the scenario is different. Here the mother is continued to remain hypothyroid, and we are presuming that she has got a stimulating antibody which has crossed the placenta. In that scenario, I think very judiciously use the both combination of, again, part of the BRT. But I think the situation is more theoretical than clinically likely to be implemented.
Sir, have you seen central hypothyroidism in this neonatal thyrotoxicosis patients once they have recovered? That is another.
Yeah, I didn't follow.
Dr. Andrew, your views, please.
Yeah.
It's, I don't know, the question was directed to me. So yes, you can get central hypothyroidism. The baby can develop central hypothyroidism if the mom is floridly thyrotoxic and suppresses the fetuses and then the neonates hypothalamic pituitary thyroid axis, and it can be transient. Or if it's severe, there are case reports of it being prolonged as well. So central hypothyroidism is common, or not common, I should say, is possible for a mom that has untreated Graves' disease during pregnancy.
Thank you. Sir, sir, I think we can go to the next talk.
I think now there will be talk by Dr. Andrew.
Yes.
Yes.
Yeah.
Thank you, Dr. Anil Bansali and Dr. Sudhir. Very good case discussion.
So I think you can invite now Dr. Andrew.
Yes.
Okay.
Yeah.
So Dr. Andrew is the director of the Thyroid Center, Division of Endocrinology and Diabetes, the Children's Hospital of Philadelphia. He's Professor, Department of Pediatrics, the Perelman School of Medicine, the University of Pennsylvania. He's Chief Pediatric Endocrine, he has worked as a Chief Pediatric Endocrine Services in US Army from 2004 to 2008. He is member of various pediatric endocrine guideline task forces in the US, and he has also been editorial reviewer of various international pediatric endocrine journals. Thank you very much, Dr. Andrew, for accepting our invitation and come to give us this very exciting talk. We are all waiting to listen to your talk. Welcome from India. Deepa, he is going to share the slides, or you are sharing?
No, sir is sharing this slide.
Okay.
Very good. So you can see my slides?
Yes, we can hear you and we can see the slides.
Perfect. So first, congratulations to Dr. Ranjan for a very nice presentation, and to the team for managing a very sick neonate. Neonatal thyrotoxicosis has still a high morbidity and high mortality. So recognizing it and the multidisciplinary care that baby received is really a compliment to everyone who was involved in helping to take care of the baby. And the picture at the end always warms our hearts, I'm sure, for everyone on the call, to see a sick infant turn into a beautiful baby. So congratulations to the team and to the discussion. So all the things that Dr. Bansali had mentioned, of course, I agree with, and some of those will be brought up again in my talk, which is mostly focused on kind of the more typical presentation and kind of a clinical approach to the treatment and prognosis of Graves' disease in children, but I threw in some slides for neonatal thyrotoxicosis as well. So thank you to everybody for the invitation. Of course, as we all say, we wish we could be in person, but it is what it is, and it's nice to have some virtual opportunities to increase our international community. And of course, thanks to my team at CHOP, which I just list here, just to show that it takes a team at every one of our hospitals to help take care of our patients. And I'm no different than anyone else. It really is my nurses that really help run the show, and then a big support staff, because we have a big clinical and translational research program. And then all the other colleagues that I have at our hospital, from surgery to radiology, interventional radiology, and everyone else that's involved. These are my disclosures. Neither of these will be part of the talk, so just for a matter of disclosure, but I won't be discussing these in the talk, and this is just the objective. So it's mostly a clinical review. I'm not going to read through these. Let's just talk about Graves' disease in pediatrics. So this is a slide that Susan will probably bring up, but for this group, we don't have to go over the details, but it's the feedback loop for the hypothalamic pituitary thyroid axis. And just to remind all of us that, the thyroid produces mostly the prohormone T4 and some amount of T3, and then that's peripherally converted, deiodinated to the active hormone that binds to the nuclear receptors, which is T3. TSH is a glycoprotein that has a similar alpha subunit with the rest of the glycoproteins that are produced by the pituitary. And so measuring the alpha subunit is helpful in patients that have prolactinoma, or in the rare, especially in pediatrics, patient where you're considering a TSH producing macroadenoma. Otherwise, we don't really measure alpha subunits, and it's the beta subunit that confers the specificity at the end organ, in this case, at the thyroid, at the end organ and the thyroid gland. So TSH binds to the receptor. It's a G protein coupled receptor. And then there's the downstream activation of the signaling pathways that lead to increased expression of the sodium iodine symporter, increased expression of the thyroid peroxidase enzyme, thyroglobulin synthesis, and then organification of thyroglobulin and attachment of thyroglobulin to the thyroid hormone, where it's stored, one of the few organs in our body that actually stores a hormone and then secretes it. So it is a binding protein, and it was mentioned in the discussion that in this case, we're talking about an antibody that binds to the TSH receptor, but there are cases where there's activating mutations and genes involved in this glycoprotein. So gene AS for McEwen-Albright syndrome, or just autosomal dominant activating mutations in the TSH receptor gene itself that can lead to non-autoimmune neonatal thyrotoxicosis. So TSH binds to the receptor, and I'm not going to go through again the details of thyroid hormone production in the thyrocyte, but as already been mentioned, there are certain proteins that we measure antibodies against. So you can measure antibodies against TSH and against thyroid peroxidase, against thyroglobulin. And then, as Susan, I'm sure, will bring up, many of these enzymes that are involved in thyroid hormone production can now have been identified as being potential etiologies of congenital hypothyroidism. So if genetic testing is performed because of something, if there's a history of a transmission pattern that fits a transmissible disorder for congenital hypothyroidism. The other protein that we won't talk about today, which is another one of my areas of interest, is MCT8 and Allan-Herndon-Dudley syndrome. So that's important not only for getting T3 into the central nervous system, but also for allowing thyroid hormone to be released from the thyroid cell, from the thyrocyte. So autoimmune disease, as we know, as a group, it has variable penetrance and expressivity, as this mom clearly displayed to all of us. Some patients have hypo, some patients have hyper. Some patients and some members of the family won't have any of those, and then other autoimmune diseases can also cluster in the family. With thyroid disease, of course, the most common would be celiac. If you have thyroid disease, and the second most common would be celiac, or vice versa. If you have type 1 diabetes, and thyroid would be the second most common for an individual patient with autoimmune disease. There are genetic factors that we know about, but we don't necessarily test for, that increase the risk. And then there's environmental triggers that then have the person with a genetic risk to display the clinical symptomatology that ultimately ends up being an autoimmune disorder, in this case, thyroid. Despite what Google says, there are not really any things that we know of that can allow our patients to avoid developing autoimmune disease, at least in the United States. There's many people trying to go gluten-free that don't have celiac to try to prevent autoimmune disease. There's just no evidence to showing if you don't have celiac disease, that going gluten-free prevents the development of autoimmune disease if it's something that runs in your family. The autoimmune process that's involved in either destruction, which is at the bottom left of this slide, or overproduction of the antibody that leads to autoimmune hyperthyroidism, is a very complicated process that involves, it's beyond my knowledge as an endocrinologist, but it involves the two arms of the immune system, Th1 and Th2, and an imbalance that ultimately leads to an increased expression of autoimmune disease in a person. In the global sense, there's something called the hygiene hypothesis, where developed countries have an increased risk of developing autoimmune thyroid disease, likely because of our obsession with cleaning and antibiotic use. And if you look in the opposite direction, there's a correlation between intestinal parasitic disease and a decreased likelihood for developing autoimmune disease, which I think all of us are grateful that we don't have parasitic disease, but the consequence is that autoimmune disease is more common in developed countries. As was discussed by Dr. Mansali, this is a spectrum of disorders. And so this is how I think about autoimmune thyroid disease. They're not mutually exclusive. They can occur in the same patient, but one is more at one end a destructive process where the immune cells are destroying the thyroid. There's germinal center deposition into the thyroid gland, and you get cobblestoning appearance on ultrasound, and you get sclerotic banding, and ultimately then dysfunction in a need, and TSH goes up in a need for thyroid hormone replacement. At the other end, you get a gland on ultrasound that looks just more enlarged. So you get to develop a goiter. And if you do ultrasound, then you can see increased blood flow for either of these things. So that's not super helpful. But I think there is an ultrasound pattern that's more consistent with the destructive and the stimulatory process. As we mentioned earlier, this is a feedback loop, and TSI kind of is a rogue form of TSH is how I typically explain it to the family. And so it's like you're in a car and the car is going up 80 miles an hour and your foot's not on the gas. So the TSI is just attaching to the TSH receptor without any regulation. And that's my simple explanation to our patients. It's listed as 1 in 10,000. I don't think we have a great handle on what the actual prevalence of this disease is, but I think all of us in practice have seen that there's more patients that are developing it and at a younger age. So when I was in training about 20 years ago, we rarely saw patients with autoimmune thyroid disease that were pre-pubertal, but all of us now I think are seeing that within clinic. That's true for autoimmune hypothyroidism as well as Graves' disease. And we have patients that present even prior to age 5 years of age with Graves' disease. Signs and symptoms, again, we won't go through for this crowd, but the most common, of course, that we see is an enlarged thyroid. If you listen, you can hear blood flow, and then you can read the list. And in pediatrics, which we don't talk about very often, is proptosis. So we rarely see active thyroid disease, thyroid eye disease, but we definitely see proptosis. And it's probably about a third of our patients. The ones that develop it often develop it early on in the course of disease as part of their presentation and rarely develop it further on. And there's a clear correlation between the TSI level or TRAB level, TSH receptor antibody level, and the development of proptosis. So it is common in pediatrics, but fortunately, the active inflammatory disease that's a risk to vision is not very common in our patients. Symptoms are very different than hypothyroidism. So we all struggle when patients come in and they're complaining that they could be hypothyroid, because all of us are hypothyroid. If we go through the list, they're not specific signs or symptoms. But for Graves' disease, it's much different. So restlessness, fidgetiness, not sleeping well at night. And again, we won't go through all this list, but there's some that I really focus on during my exam to help increase the likelihood. And most of us, I think, when we walk into a room, can almost diagnose it from the doorway. When you see a patient that's just fidgety on the table, if they have proptosis, thyroid eye disease, or if they have a large thyroid. And so this can be a visual diagnosis for all of us that are on the call, because we're used to seeing this, but for pediatricians, something to look at that list and remember what it looks like. The three things that I really want to just drive home for symptoms are weight loss. So very common to have increased, you have hyperphagia, increased appetite, but still have weight loss. And the issue with this is that you can overcompensate. So once you control the Graves' disease, for patients that were overweight prior to developing Graves' disease, they have a high likelihood of overshooting. And if they don't back off on their habit of eating frequently in larger amounts, they can gain weight above where they were percentile-wise at the time of diagnosis. This seems to be more common in females and younger age patients at the time of diagnosis. So something really to highlight to the family to make sure that they're kind of watching the bad habits that their child was getting away with as the Graves' disease is under control. As far as growth, there is enough evidence to show that there is a potential for growth acceleration. It's more common in puberty. So if you look at the graphs on the right, so pubertal boys can have an increase in their percentile as far as their height gain. They can advance their bone age to some degree. But ultimately, when they complete puberty, you control the Graves' disease and you complete puberty, because it oftentimes delays puberty if you have uncontrolled Graves' disease, you don't gain additional height. So it's just something that can be observed. So if you see an increased height and they're dropping weight, they're tachycardic, it's another thing that you should think of, although most of the time you can make the visual diagnosis without even looking at their linear growth curve. And then this is the most important. And we have patients that, this is a disease that kind of slowly sneaks up on patients. It's not your normal one day and abnormal the next day. And so we have a number of patients that are for ADD, and when they didn't have it at the start of school, and all of a sudden they're entering high school, and they're diagnosed with late onset ADD or anxiety disorder or tachycardia, and they're sent to the cardiologist, and then ultimately they're diagnosed with Graves' disease. So if a patient for primary care doctors, does not have a history that's consistent with ADD that was noted at the time of beginning school, you need to think about hyperthyroidism as an etiology of late onset ADD. There does not seem to be a correlation between the level of biochemical thyrotoxicosis, so how high the T3 and T4 are, but we have a study that we're just getting ready to publish. These signs and symptoms will resolve once you normalize the T3. So we recently did neurocognitive batteries when the T3 and T4 were elevated, and then after, for the same patient, normalization in all these domains that are consistent with ADD and ADHD resolve with the normalization of the thyroid hormone levels. For neonatal hyperthyroidism, this is the list, and I think the patient that was presented so nicely fit many of these signs and symptoms that have been previously described in neonatal thyrotoxicosis. Again, interestingly, that this patient unfortunately didn't have maternal history. It was just picked up clinically. But all the things that are listed on this are possibilities for babies that are born to moms with uncontrolled Graves' disease. What do we do for labs? So I think for many of us, especially primary care, TSH is oftentimes, the only thing that's screened for, and then there might be a reflexive T4, and T3 is not very well thought of. But in hyperthyroidism, T3 is critical. In early Graves' disease, you can have a predominant T3 elevation. And so that's really important to measure the T3. I also measure it in hypothyroidism, which we could talk about later, and then thyroid autoantibodies. And for some patients, they come in still and they say, they have anti-TPO and anti-TG, and they have Hashimoto's and Graves' disease, and it's just not true. Again, it's that spectrum, and 50%, up to 50% of patients with Graves' disease will have the other thyroid autoantibodies as well. And so the diagnostic antibody is the thyroid stimulating antibody or TSH receptor antibody, which is just measuring competitive inhibition of a labeled TSH monoclonal antibody against the receptor. So it's a competitive assay versus a cell-based bioassay. Between the two, the TRAB assay is less expensive and has a shorter turnaround time, and the more recent third-generation versions are highly sensitive and automated, and I think they're quite useful clinically compared to when I was starting training. But I still like TSI because it really measures the stimulating antibody level rather than just a general blockade of the receptor through a competitive assay. As far as imaging, ultrasound, I have point of care ultrasound that I use in clinic. I think it's highly informative. And for most patients, then I don't require scintigraphy. So I rarely use radioactive iodine uptake in scans. To make the diagnosis, you can make it just based on clinical signs and symptoms, the TSI or TRAB level, and then plus minus an ultrasound. And so ultrasound is highly informative and helpful for patients that may not have elevated TSI, where you're looking for an autonomously functioning nodule, or for patients just to confirm the diagnosis if you have point of care ultrasound. As was mentioned, for our patient that presented with neonatal thyrotoxicosis, placental antibody transport is highest in the third trimester. So that's the most critical time for maternal transmission of the TSI to the fetus. And so measuring at around 20 to 24 weeks gestation, if the mom has a known history of autoimmune thyroid disease, or they had Graves' disease that was treated with radioactive iodine and still might have antibodies, or there's a number of clinical situations, that's a time to check the maternal thyroid autoantibodies, specifically TRAB and TSI. And then when the baby's born, you can also measure it in the cord blood, and those provide the highest prediction of a baby if they're going to be at risk or not. But it's the baby's thyroid function that is the determinant whether the baby needs treatment or would benefit from treatment or does not require treatment. So in pediatrics, with uncommon exception, I think all of us treat our patients with antithyroid medications prior to thinking about definitive diagnosis. These are the medications that we use, as already been described, so we won't go through all of these, but if they're highly clinical symptomatic, we'll use beta blockers, waiting for the antithyroid medication to work. And then once the T3 and T4 are normalized, then the methimazole can be stopped, or carbamazole. Iodine is also highly effective, and how this works, of course, is the Wolff-Chaikoff effect. And so we use Lugol's or SSKI, supersaturated potassium iodine, clinically for patients that present with thyroid storm, which neonatal thyrotoxicosis is kind of a subversion of that. And we also use it for our patients prior to surgery. It decreases VEGF expression, vascular endothelial growth factor. And for patients that are poorly controlled, it can normalize the T3 and T4. It typically takes about 7 to 10 days for that to work. The escape from the Wolff-Chaikoff effect is prolonged in neonates, and I think it's also relatively long in older patients as well, as I've had patients on SSKI that had an adverse reaction and waiting for surgery for weeks, and actually several months without escape. So it's not a good first plan, but for patients that are on it and you're waiting to have the surgery, as long as they're monitored, it can be highly effective for a longer period of time than most of us are taught about in school. Methimazole takes about 1 to 3 months to work, or carbamazole, which is converted to methimazole. And there's a relatively high concentration that accumulates within the thyrocyte that ultimately the mode of action is to decrease the function of thyroid peroxidase. In the States, and probably in your practice as well, we don't use PTU anymore, even though I used it on most patients in training before we converted to methimazole. So because it's uncommon, but highly severe as far as liver toxicity, PTU is not being used in pediatrics anymore. So methimazole is what we use. I used to kind of dose per kilo, but I think now in pediatrics, the easier way of thinking about it is a milligram per age. So a 5-year-old starts on 5 milligrams, a 10-year-old on 10 milligrams, a 15-year-old on 15 milligrams. And that's a nice starting point that kind of balances over treating and not starting at too low of a dose. And then I check labs every month. I don't see the patient every month as an outpatient, and then start backing off once the T3 and T4 normalize. Back from the PTU days, I think we're all in the habit of sometimes prescribing methimazole on more than once daily dosing, but it's been known since the 80s that methimazole, even though it has a serum half-life of 5 to 6 hours, it has a much longer tissue half-life. So it's a good once-a-day medicine. In severe thyrotoxicosis, we separate that into 2 to 3 days, as was done for this neonate. So once daily dosing is adequate. And even for patients that are on minimal dosing, I have some patients on Monday, Wednesday, Friday, 2.5 milligrams, waiting for their TSI to normalize. So you can even use alternate day dosing because the tissue half-life is longer than the serum half-life. Adverse reactions typically happen within the first 3 months. This is one of several studies from Scott Rivke's, and there is, I think, a dose correlation. So the higher the dose, the higher the risk. And once you get out of this time frame, the risk decreases. So this is probably the best study to date. It's in pediatrics from 2014 from the group in Japan, looking at just a massive number of pediatric patients with hyperthyroidism and going through the side effects between methimazole and PTU. And the two most common, of course, are hives and joint pain as far as side effects. Hives can be a presenting factor for Graves' disease, or they can develop after starting methimazole. For patients that present with hives, typically starting methimazole makes it worse, and it's much harder to get under control. For patients that do not have hives at presentation, develop it during methimazole, stopping the methimazole, starting an antihistamine, and then trying to restart at a lower dose oftentimes works. So we can usually work through hives, just depends on how they present, but hives can be significant. And so not every patient can tolerate the methimazole, even though this isn't a severe reaction, it's not like a serum sickness reaction, it can be significant enough that patients can't live with hives that are that large and that symptomatic. Arthropathy is a little bit, I think, more difficult to manage. If someone develops arthropathy, I think there's just a less likelihood that stopping it, even going on NSAIDs and then trying to restart it works. Most of our patients that develop methimazole-induced arthropathy ultimately have to seek definitive therapy. It's just harder to work through, and that may be because it's somewhat related to a vasculitis that can occur at the same time. The two most concerning adverse reactions, of course, are liver dysfunction and neutropenia. Both of these you can see from this this figure are less than 1% of our patients. And I think in practice, I've seen maybe 2 cases of transaminitis in the last 10 years associated with methimazole, and maybe 4 to 5 times that as far as methimazole-induced neutropenia. So neutropenia is more common. Both of these are not very common, but patients need to be aware of it. And if they have a fever, they need to get a CBC to ensure that they're not developing methimazole-induced neutropenia. If and when that occurs, I think all of us would agree, at least in my practice, I don't you stop it, they recover. I don't restart methimazole. I don't switch to PTU. If they develop an adverse reaction that's less than 1%, it's time to move towards definitive therapy. How many patients achieve remission and relapse is just the last part of this talk. And so for many years, we try to come up with clinical parameters that would identify patients that would ultimately achieve remission. And it turns out that really none of these hold true. So there was a number of papers 20 and 30 years ago that tried to use these parameters to help predict remission. But what turns out, it's time is the best predictor. So if you still have methimazole, you still have elevated antibodies 6 to 8 years after diagnosis, your Graves' disease is likely not to go away. So the first study was from Leger in Paris in 2012. And then again, from that wonderful study that came out of Japan in 2014, again, showing that the likelihood of remission somewhat plateaus around between 5 to 10 years after diagnosis. That doesn't mean you have to move to definitive therapy, but just to explain to the patients, it's likely not to go away if they are 5 years or more after diagnosis. For patients that are lucky to have their TSI normalize, there's still about a 40% relapse. And so this study showed 50%, but I think in practice, it's somewhere closer to 40%. And so we warn our patients, and when we are in that lucky scenario where the TSI normalizes, and we follow serial TSI measurements, typically 1 month, 3 months, 6 months, and maybe 1 year after, that's the biggest risk factor for relapse. What factors predict relapse, I've kind of already alluded to, is the TSI is really the only helpful one. So if they have a goiter, they have Graves' ophthalmopathy, those are helpful. I've been looking at ultrasound to see if at the time of stopping methimazole, the degree of blood flow on Doppler of the ultrasound is helpful. And there seems to be some correlation, although I haven't done enough data analysis yet to figure that out. But ultrasound may ultimately be helpful. When I was in training, at least my mentor said that following the antibody levels is not very helpful because it doesn't predict who's going to have relapse. But if you actually look at the data from the 80s, the patients that have elevated antibodies have persistent Graves' disease. The patients that have normal antibodies are likely to maintain their remission. And that just makes sense on a clinical scenario. If they have normal antibodies, it doesn't mean they won't relapse, of course. But that's why we check once you stop the methimazole or carbamazole to make sure they're not having a relapse. Overall, I think it's about 20, maybe 25% of patients that achieve remission. And that's what I tell our patients. So between diagnosis and 5 years, if it's smooth sailing, then we just keep going with treatment. If it's a rough course, if it's only 20% of patients that achieve remission, that's when we think about moving towards definitive therapy. There is no length of time, even though I wrote about this years ago, that is too long to be on methimazole. If you're tolerating it and there's no adverse reactions, then you can stay on treatment. There's just no reason that you have to stop it. And so that is a discussion with our patients, and it's up to them what they want to do. So no, if they're not having side effects, you can continue it. If they are having side effects or they've reached 5 years and they're ready to be done, then surgery versus radioactive iodine. So the timing really just depends on if they've had adverse reactions or not, and if their disease course is smooth or if it's disruptive to their daily activities. So time is not the metric. And then it's patient and family interest. In our practice, and I asked at the beginning of this talk, or the beginning of this gathering, is what's more common in your community compared to the United States. And in my hospital, thyroidectomy is more common. It sounds like it's the same even in India, but I think that's institute and practitioner dependent. How do we choose? Well, radioactive iodine, typically it's negotiable, but patients are typically more than 10 years of age. Their gland is not significantly enlarged, more than 4 times enlarged. And there's no nodules on ultrasound. So I ultrasound all patients as part of the decision whether radioactive iodine or thyroid surgery would be effective. And that's because if you find nodules in the setting of Graves' disease, there is a potential for concomitant thyroid malignancy, papillary thyroid cancer being the most common. And then if they have eye disease, so even if it's not active eye disease, using radioactive iodine can worsen it because antibody levels will increase afterwards. The two last considerations as we head towards the end of the talk is keloid formation if it runs in the family. So we always talk about keloid formation with our patients. And then it's just the time to achieve remission. And so radioactive iodine is wonderful because it's not surgery, but patients need to realize 1 to 3 months to achieve hypothyroidism, and sometimes even up to 6 months after treatment. And for many of our patients, which are more commonly adolescent girls, they don't want to wait the 3 to 6 months. They want to be done with this and move on without having to go through 3 to 6 months more of labs and follow up and symptoms. So in our practice, we have 2 high volume surgeons, and you only move towards thyroid surgery, and it sounds like in your practice, hopefully this is true as well, if there's a low risk for complications. So we have less than 1% risk of permanent hypopara and recurrent laryngeal nerve damage in our surgical group. These we won't go through, but this was brought up in the question period. So what happens to babies that have neonatal thyrotoxicosis? And for the most part, it's transient, and we already went through that. They can develop primary hypo, or they can develop central hypo, and all those things are possible. And this is an article that we published in 2017. The drugs, we won't go through, they're the same that's been used, and it was so nicely displayed during the case presentation of that infant. So it's usually multi-drug therapy and symptomatic support that decreases the morbidity and mortality for neonatal Graves' disease. The one thing that we didn't talk about is exchange transfusion, which can be highly effective for patients that are really undergoing cardiovascular compromise. Exchange transfusions in neonates and even in pediatric age patients is highly effective to help resolve the thyrotoxicosis in extreme situations. Again, this is a flow chart that was shown by Dr. Ranjan, something similar as far as how do you treat and how do you follow. And so we won't go through this just for time, but it's in the 2017 article that we published. And usually this is a transient thing. And breastfeeding we talked about, so I won't discuss that any further as well, but it's not contraindicated. All right, so in closing, all these treatments work, and so that's what we tell our patients. Antithyroid meds is usually how we start. And then definitive therapy, really, there's a number of things that we consider, and it's a patient discussion and a patient decision of if, when, and which definitive approach is best for that individual patient. So there isn't a treatment of choice. It's fortunate that we have 3 different approaches, and all of them are effective with the same goal of achieving euthyroidism if they're lucky, if they achieve remission, or hypothyroidism if they pursue definitive therapy. So as I mentioned, we'll have this publication hopefully in the next year on neurocognitive function and Graves' disease. We have another study looking at health-related quality of life after surgery in our patients that have thyroidectomy for definitive therapy. And with that, I'm a couple minutes over, but I'll end, and we'll see if we take questions now or after the next case presentation in the lecture by Susan. So thank you to everybody for your attention.
Thank you. Thank you, sir, for that excellent lecture. We have a few questions in the chat box. The first question is that, how do you treat neonatal fetal thyrotoxicosis with maternal hypothyroidism? It was diagnosed around 30 weeks.
How do you treat a mom that develops thyrotoxicosis at 30 weeks for the baby? Is that the question? So you treat the mom, and the methimazole crosses the placenta, right? Or carbamazole. So as a pediatric endocrinologist, I'm not directly responsible or taking care of moms that develop, maternal thyrotoxicosis. It's our adult endocrine team. So that's at least the approach that I am aware of. But if there's some adult endocrinologists, they do something different, I'd like to hear that as well. So if there's someone else. For fetal goiter, for hypothyroidism, we have had some patients that have congenital hypothyroidism with TPO or TG mutations and significant goiter that's leading to issues for the fetus, but you can use intraamniotic levothyroxine. I haven't heard about the opposite of using something like antithyroid medication in an intraamniotic fashion. Is there any adult endocrinologists that do things differently for maternal hypothyroidism at 30 weeks?
No, it would be the same.
Yeah. Okay.
The next question is that, you say, is there a role of stopping gluten in family members with autoimmune thyroid disorders?
No. So there isn't a lot of data. And at least in the United States, there's many people trying to go gluten-free and paleo and all these diets and then they claim they feel better, but there's really no data to show that going gluten-free decreases the risk for developing autoimmune disease. And there are 1 or 2 studies looking at patients with celiac that need to go gluten-free, and they still show that those patients ultimately are at risk for developing other autoimmune diseases such as autoimmune hypothyroidism and hyperthyroidism and others. So there may be a subgroup of patients where the gluten-free might be helpful, but as a general approach to the population, to the average patient, I do not recommend going gluten-free. And all of us know what a nuisance that is. Dietarily, if you don't need to do it, it's just not worth it. I'd rather take levothyroxine and methimazole than be gluten-free. And that's what I try to convey to our patients.
Because it's a big fashion or practice to stop gluten for every diseases, and
Exactly.
blame gluten for everything. Thank you, Dr. Andrew.
And then they get gluten sensitivity, and then every time they eat gluten, even though they don't have celiacs, then their stomach hurts. And then they stopped it to try to make their stomach stop hurting. But I think we're all there, and we're in clinic and pulling our hair out trying to convince them otherwise.
Yeah, next one.
Another question by Dr. Anju is that how would you ultrasound help to distinguish between Graves and thyroiditis? Can it differentiate ultrasound?
So between Graves and autoimmune thyroiditis, I think it's again, it's not a perfect distinction, but if you see cobblestoning and sclerotic banding, it's more commonly to be Hashimoto's, and if you just see kind of heterogeneous echo texture, but it's it's more uniformly heterogeneous rather than irregular in cobblestone, then that's more consistent with Graves. So I think the ultrasound is helpful, but it's really a clinical diagnosis, right? I mean, all of us have walked in a room and you can tell if someone's floridly hyperthyroid. So I use it for subtle cases, and I have point of care ultrasound. So I'm obsessed with it. I ultrasound everybody just because I'm comfortable doing it, and I just use it as part of my exam.
Another question is, what are the possible causes of high free T4 and free T3 with unsuppressed TSH in newborn and euthyroid mother born to consanguineous causes?
So thyroid hormone resistance would be on the list, right? So if you have elevated T3, T4, and non-suppressed TSH, then thyroid hormone resistance beta would be the most common, would be on the list. If you have isolated elevated T3 with a non-suppressed TSH, and it's a male infant, then you need to think about Allen-Herndon-Dudley syndrome. But thyroid hormone resistance with that clinical situation would be high on the list. Other things obviously could be assay interference as well. And so typically, like we know that biotin now interferes with some of these assays, but usually in that situation, it's more pseudo-Graves. So you may have an elevated T3, T4, but you'll have a lower TSH also. It just depends on which assay and what interference occurs. But that's the list. Thyroid hormone beta, resistance to thyroid hormone beta, and then potentially lab interference.
Next question is, methimazole-induced agranulocytosis with febrile neutropenia. Can we use iodine? And if yes, how to titrate the dose?
So when patients develop methimazole-induced agranulocytosis, then you stop them the methimazole, and then if you have to control the Graves' disease, then you use propranolol. It helps decrease T4, T3 conversion. You add SSKI. You can add glucocorticoids. You can use cholestyramine as a binding agent through the intestinal tract. And so all those are on the list of trying to treat the biochemical thyrotoxicosis if you can't use thionamide. When that happens, and what we tell our patients is, one, we're not going back on methimazole or carbamazole, and two, because now iodine loading you, once you're under control, we're going to move towards surgery. And so that's the typical course for the patients that develop this. I've had a number of patients, mostly consults, where they've used granulocyte colony stimulating factor for some patients if they're septic, and the ANC is not recovering in a fast enough time frame clinically. So that's something that, at least in our practice, is considered, but we work with hematology and oncology if we're thinking about using GCSF to help with the MMI-induced agranulocytosis recovery.
So, another question is once a day carbamazole can be applied for carbamazole also, like methimazole? Because methimazole is very don't get daily in India.
Yeah, for a while I hadn't seen it at all, and I just didn't believe that we were going to see transaminitis from carbamazole and methimazole, but we've had at least 2 patients, and so we've gone through was it autoimmune hepatitis and just unrelated to the drug, or was it really drug related? And at least in the last patient, the autoimmune hepatitis evaluation was negative. We stopped the methimazole and they recovered. And so, as I said, I think it is possible. It's just uncommon, or less common than the already uncommon agranulocytosis. But it can happen. It absolutely can happen, at least in my practice. And it's only a couple patients, but a couple patients is enough to remind us that it's a possibility.
So what are your thoughts on block and replacement therapy for Graves?
So again, in training, people said don't use block and replace, and I think, at least looking back, it was probably because of, why would you add another drug when you can decrease the PTU, and there's a dose relationship between the dose of PTU and the potential risk for side effects. And so I was taught not to use block and replace because of that. But now I do have patients that we use block and replace on, and typically the situation is that they're TSI positive, and so I can't stop them methimazole or carbamazole, and they're on low dose methimazole or carbamazole, half a tablet a day of the smallest tablet, and they're still hypothyroid. And so the only way out of that is to add some T4. So the 2 options we usually give patients is go to alternate day dosing and see if that works, Monday, Wednesday, Friday, or stay on daily 2.5 milligrams of methimazole and add some T4, waiting to see if that TSI goes away. So I won't stop methimazole until I know the TSI is normalized, and I usually actually wait with at least 2 in a row, a month to 6 weeks apart, just to be more comfortable that a normalization of TSI is at least stable prior to stopping it.
We are running short of time. Shall we go to the next session, because
We're a little over. Yeah.
Thank you,
Great
Dr.
questions.
Andrew.
Thanks, everybody.
Thank you. If you could answer the other questions in the chat box, we really appreciate it. There are
Absolutely.
a couple more. Yeah. Thank you very much. Thank you.
Yeah, thank you.
So, Deepa, we'll move on to the next.
Ankit?
Yes. Rekha?
Yes, ma'am.
Yeah. Okay. For next case discussion, we have moderator Dr. Vijay Kumar, Professor, Department of Pediatrics, Government Medical College, Kerala State, and he is the President IAP Kerala, and he is past State Secretary ISPAE, and he is the State Coordinator for Newborn Screening and also Nodal Officer for MITAI program. And Dr. Rekha is a fellow in pediatric endocrinology from Indira Gandhi Institute of Child Health, Bengaluru. So we can start the case, Rekha.
Yes, ma'am.
Hello, good afternoon. In the next case, we are going to discuss about a common and preventable condition which, if not adequately picked up early and not followed up properly, can result in a devastating situation. This condition can be picked up with a relatively inexpensive newborn screening program, which unfortunately is not universally done in India. The newborn screening, I say, is the birthright of a baby, just like breastfeeding. And in Kerala, we have started our newborn screening in government hospital in 2013, and so far we screened 4 lakh neonates, and 260 cases became positive, and it shows very high number actually, 1 in 1,500. That is not a very rare disease. So I invite Dr. Rekha. She is a fellow in Department of Pediatrics and Adolescent Endocrinology in Indira Gandhi Institute of Child Health, Bangalore. Over to Dr. Rekha.
Thank you, sir. Good evening to all the dignitaries, professors, and my dear colleagues. I thank ACES for giving me this opportunity. Today we will be discussing about a severely stunted child, a neglected case of common treatable cause. Our objectives are how important is newborn screening and the need for regular follow-up in congenital hypothyroid children and the complaints in those children. He is a patient, 13 years, 7 months old male child residing from Jiganahalli, Muslim per religion, mother being the informant. The child was brought with chief complaints of not gaining height, noticed from early childhood, with history of developmental delay, noticed from infancy. Coming to history of presenting illness, history of grossly delayed development, noticed from infancy. However, the mother is unable to recollect the milestones and gives only the present attained milestones history. There was a history of severe chronic constipation where the child passes stools once in 8 days, which is not associated with and is associated with pain, noticed from infancy period. The child also has a history of thickened and severe dry skin, noticed from early infancy. There is a history of severely stunted growth noticed from early childhood. However, mother and elders in the family felt that the child was normal and would grow gradually. But when they started comparing the child to his younger sibling, they felt the child was not growing proper, and they had brought him to our OPD. Coming to negative history, there was no history of visible bony deformities or fractures, no history of seizures, and no history suggestive of chronic systemic illness. Past history, during 10th week of routine vaccination, the mother had complained that the child was having constipation. Upon investigation, the child was started on some medication which was to be given early in the morning, and the child received it only for 10 days approximately. The mother says she was unaware that the medication was given for thyroid disorder, and she thought it was for constipation, and since the constipation did not improve, due to their personal beliefs, they have switched over to Ayurvedic medication, which was also discontinued later on. Coming to birth history, the child was full term, delivered by LSCS, 2.5 kgs of birth weight, cried immediately after birth. There was history of NICU stay on day 3 of life in view of prolonged jaundice for a total stay of 8 days. Coming to developmental history, the mother could not recollect the developmental history of the child and is only able to give the present development milestones which the child has been attained. Currently, the child walks without support but cannot run or climb the stairs, where his developmental age falls at 1.5 years with a developmental quotient of 11. Fine motor, he is able to scribble, which corresponds to 1.5 years of developmental age with development quotient of 11. Social, he can ask for his needs and indicates for toilet need and plays with his siblings, corresponding to 2 years of developmental age with a developmental quotient of 14. And language, the child is able to talk 2 to 3 word sentences, which is only understandable by the parents, but not by the other people. Coming to vision and hearing, he follows objects, responds upon calling his names, and parents says he obeys the commands given by the parents. Immunization history, the child was immunized only up to 1 year of age. Family history, the child was a firstborn to second degree consanguineously married couple. However, there were no history of developmental delay or similar complaints in the family or in the sibling. Summary, 13-year-old child, firstborn to second degree consanguineously married couple with a history of prolonged neonatal jaundice, was brought with complaints of chronic constipation, severe dry skin, gross developmental delay, with severely stunted growth noticed from early childhood, for which no medical help was taken. On examination, this 13-year-old child, when he walked into the OPD, just looked like a 2-year-old. That says he's severely stunted with a dull look on his face, with vitals being stable except for bradycardia, which was regular in rhythm. He had puffy face with thick lips and macroglossia, depressed nasal bridge, no goiter, hoarse voice, thickened and dry skin, umbilical hernia was seen. Systemic examination of RS and CVS was normal. Per abdomen, it was soft, no organomegaly, no tender, and umbilical hernia was present. Deep tendon reflexes had delayed relaxation. SMR staging, he falls in Tanner stage 2 with stretched spinal length of 5 centimeters with testicular volume bilaterally being 6 cc. Anthropometry, the child's weight was 15.14 kgs, which falls in less than 3rd centile, as we can see on the growth chart, with a z-score of minus 7.7, and height at 89 centimeters, with falling in less than 3rd centile, with a z-score of minus 4.97, where his weightage corresponds to 3 years 6 months and heightage corresponding to 2 years 2 months, with BMI for 19.1 kg per meter square, which falls more than 50th centile. Head circumference is 49 centimeters, and upper segment is lower segment ratio is 1.2:1, with mid-parental height of 166 centimeters, which is between 3rd and 50th centile, with his body surface area of 0.6 meters square. From this anthropometry, we can interpret that height age is more affected than the weight age compared to the chronological age. This is the child with his younger sibling who is 11 years old, developmentally normal, studying in grade 6, with a height and weight being normal between 10 to 25th centile. So there's a gross difference between the younger sibling and the elder sibling. That is when the parents wanted medical help and they have come to our OPD. In summary, a 13-year-old child was brought with complaints of chronic constipation, severe dry skin, gross developmental delay with severely stunted growth noticed from early childhood, along with a history of prolonged neonatal jaundice. On examination, child was severely short-statured with height and weight being markedly below 3rd centile with coarse facial features, hoarse voice, macroglossia, umbilical hernia, and delayed deep tendon reflexes. So we thought of it could be a case of congenital hypothyroidism, but we also thought we should rule out mucopolysaccharidosis, for which on investigations, the TSH levels were elevated, TSH being 503.7 microinternational units per ml, free T4 being on 0.08 nanogram per deciliter, total T4 of 0.42 microgram per deciliter, with autoimmune panel of an anti-TPO, anti-TG being negative. And rest of the basic investigations were within normal limits. Coming to his bone age was calculated according to Tanner-Whitehouse method, where it was corresponding to 2 years 6 months. However, the X-ray of hand did not show any bullet-shaped appearance of metacarpals, and skeletal survey done for the child showed normal. There was no any changes in the spine. Ultrasound neck was done for the child, where the thyroid gland was seen normal in position. Coming to thyroid nuclear scan, the thyroid gland was mildly enlarged with increased protectate uptake, which represent dysharmogenesis. The normal uptake is 0.3 to 3%. However, in this child, there was 9% of uptake of protectate. Coming to perchlorate discharge test, the thyroid gland was normal in position, appeared mildly increased in size with increased radioiodine uptake. However, though there was increased uptake in the first at the 0 minute, after 40 to 45 minutes, there was a significant fall, which was less than below 50%, and showed a washout of 77% of radioiodine after perchlorate administration, which is consistent with organification defect. This says that perchlorate test which is more than 10% fall then the iodine uptake after 2 hours is consistent with organification defects. Coming to, hence we have come to a diagnosis that the child who presented to us with a history of chronic constipation, severe dry skin, gross developmental delay with severely stunted growth, along with history of prolonged neonatal jaundice. On examination, child was severely short-statured with height and weight being markedly below 3rd centile with puffiness of face, with thickened lips, macroglossia, umbilical hernia, delayed deep tendon reflexes with macrooptimism. Investigations also showed that there was elevated TSH levels with negative autoimmune panel and thyroid nuclear scan showing organification defect, thereby narrowing down the diagnosis to congenital hypothyroidism. We started the child on oral levothyroxine 37.5 microgram once a day along with other calcium supplements. However, we had asked the child to follow after 2 weeks after the start of levothyroxine, but due to the COVID situation, the parents were not able to come after 2 weeks and had followed up us after 2.5 months. On follow-up, we can see that the child has improved. The constipation had improved. The child alertness was improved, but the thick and dry skin compared to the previous picture, it is so much improved. And even the child was very alert compared to the first visit to us. Anthropometry on follow-up, the weight was, had been decreased by 1 kg, 14 kgs, which is still less than 3rd centile with a z-score of 7.34. Height 93 centimeters, falling less than 3rd centile with a z-score of minus 5.3. But there is an increase in height. Previously, it was 89 centimeters on first visit. And after starting of thyroxine, there was improvement in the height of the child. And BMI has also been decreased, which is 16.1 kg per meter square, falling less than 25 centile. Investigations on follow-up, however, the thyroid was on the higher elevated, TSH was elevated with 49.97 microinternational units per ml, with total T4 being 4.66 microgram per deciliter. Hence, we had increased the oral levothyroxine dose to 72 microgram per meter square per day. And we are waiting for the child for the next follow-up. Coming to discussion, congenital hypothyroidism is the most important preventable cause of mental handicap. It is more common in India than developed countries. Incidence, congenital hypothyroidism is seen in 1 in 1,000 to 1,500 children. The importance of newborn screening, coming to the newborn screening, the timing of sampling is important. Either cord blood or postnatal sample of 48 to 72 hours, which is not more than 5 days, should be collected. For a sick neonate, sample should be collected before 7 days of life or before discharge, whichever is earlier. In case of early discharge or need for blood transfusion, testing can be done between 24 to 48 hours of life, but cutoff values for recall are different. Timing of screening is the same for preterm and small for gestational age babies as in term babies. Second sampling for screening is generally done in some special situations at 2 to 4 weeks, such as in preterm child, IUGR child, sick newborn, Down syndrome, first sample after blood transfusion, or twin or multiple births. Screening strategies. Screening strategies can be either by primary TSH method or a primary T4 method. Primary TSH method is the most sensitive method to detect all forms of primary congenital hypothyroidism. However, central thyroid hypothyroidism can be missed in these children. A primary T4 method detects hypothyroidism, including central hypothyroidism, but can miss subclinical hypothyroidism. A combination of TSH with T4 is actually effective, but whenever due to financial restraints, only TSH can be done. Interpretation of results, as we told, any newborn with more than 20 milli international units per liter is screened positive. If the sample was taken between 24 to 48 hours, then the recall value is more than or equal to 34 microinternational units per liter. According to this, the interpretation is that the initiation of therapy should be started when the TSH is more than 20 milli-international units per liter in less than 2 weeks of age, or more than 10 milli-international units per liter in more than 2 weeks of age. The levothyroxine should be started. And in children with persistent TSH with normal T4, total T4, TSH being more than 10 microinternational units per liter at the age of 3 weeks, the thyroxine has to be started. And also in children where where there is values of low T4, that is less than 8 microgram per deciliter, or low free T4 values of less than 1.17 nanogram per deciliter, irrespective of the TSH values, the levothyroxine treatment should be initiated. Coming to follow-up, these children should be followed up with repeat free T4 or total T4 after 2 weeks, and TSH free T4 and total T4 after 4 weeks, after the start of the treatment or after the change of thyroxine dose on the visits. Further, T4 and free T4 and TSH has measured in the following way. With 2 monthly till 6 months of age, 3 monthly from 6 months to 3 years, and 3 months, every 3 months to 6 months till completion of growth and puberty, and every 6 to 12 months thereafter. Hereby I end my presentation. Thank you very much.
Thank you, Dr. Eka. It was an excellent presentation, illustrating beautifully the unfortunate story of that poor boy who could have led a normal life if he was picked up very early and followed up properly. And even it was late, you can see the dramatic response regarding the linear growth, at least with that thyroxine. So how the main problem is, one, how the condition can be prevented. That is only by a proper newborn screening, either cord blood or dried blood spot. And in some cases, we require a second screening also, especially if the child is a preterm, sick baby or SGA baby. And always make sure that even if there is a normal screening, whenever a child shows any symptom of hypothyroidism, we have to screen again, because there is some false negative also. Actually, we had a case, it was completely normal after newborn screening. Newborn screening was normal, but the child came back at 6 months with constipation and abdominal distension, and child turned out to be hypothyroid. So that is not 100% foolproof. We have, whenever there is a doubt, we have to do thyroid function test, because that is a very cost effective compared to the era of our exome sequencing and all. It costs around 300 rupees. That won't add much for the cost of the treatment. Second thing is, in this child was diagnosed at 10th week but lost for follow-up. So that is the importance of proper counseling also, especially if the child was diagnosed by newborn screening, because that child is completely normal. The child may not have any symptom. So the child is asymptomatic, and if you advise to take a drug lifelong, the parents will get confused, and they may even stop the drug without informing you. So that is also happened. Actually, the proper counseling is very important. Third is regular monitoring. Take height, weight, development, and even see the drug compliance also. And we have to keep a diary of drug intake if in doubt of compliance. Sometimes they will stop the drug, they won't tell us. We will see a elevated TSH, we will increase the dose. Like that vicious circle will go on also. So all these things are very important. If you do a newborn screening and start treating a child with congenital hypothyroidism, because the child is totally asymptomatic, and the parents will get confused and they won't know why you are asking them to take a drug for lifelong. So with this, I'll stop the discussion. If there are any questions in the chat box, or shall I?
We can go to the next session, sir.
Okay, I think I invite the speaker now. Deepa?
Ankit?
Yes, there are not much questions actually. I think question may come after this. So with this, I introduce the speaker, Dr. Susan R. Jose. She is the Professor Emeritus, Pediatric Endocrinology, Cincinnati Children's Hospital and Medical Center, University of Cincinnati College of Medicine, an expert in congenital hypothyroidism and other thyroid disorders. And Madam has prepared the USA guidelines for congenital hypothyroidism in 2006, and in the preparation for the modification of this this congenital hypothyroidism screening, which will be coming within few months, as Madam was discussing, in 2022, and we are eager to hear this very important topic. And over to Dr. Susan R. Jose for the much awaited talk on update of congenital hypothyroidism. Over to you, Madam.
Thank you. Thank you. Good evening. I'm really happy to be here. It's been a great meeting so far, and such a fascinating case. Sad. And that's the reason why we need to have newborn screening for congenital hypothyroidism, to avoid cases like that. So, Deepa, can you please share my slides?
Yes, ma'am. Is it visible?
Perfect. So, I noticed that Dr. Bauer is saying to please feel free to contact him about other questions. So I'm going to talk about a little bit about thyroid gland development and physiology, and then about congenital hypothyroidism. And then finally, I'll talk about second screening in premature infants next. So it's relatively easy to identify an enlarged gland, but locating a normal thyroid gland can be difficult. And I'll just share with you my trick for this. I feel with my thumb for the patient's tracheal rings, and then the prominent thyroid cartilage, and then go a little bit below with the thumb, and you lose the feel of the thyroid cartilage, of the tracheal rings. And then if you have the patient swallow, you can feel a small, soft tissue that moves up and down. And that lets you locate the level of the thyroid isthmus. And then you can feel on either side for the thyroid gland. Next. So the thyroid gland originates from branchial clefts during fetal life, and the anatomy is largely complete by 10 to 12 weeks of gestation. Next. The thyroid primordium moves during fetal development, from the back of the tongue down through the neck to typically below the thyroid cartilage, but it may stop anywhere along the way and be an ectopic gland. Next. So an ectopic thyroid may be located anywhere in the path of migration, and may even be down in the mediastinum. Next slide. Usually when the thyroid migrates to an ectopic position, it usually doesn't function normally. So in the center here is normal thyroid gland regulation. There's TSH from the pituitary and hypothalamus stimulating the thyroid gland to make T4 and T3, which provide feedback centrally. If there's a problem on the left, for instance, if there's a problem with the hypothalamus or the pituitary, then less TSH is made, and as a result, less T4 is made. That's central hypothyroidism. On the right-hand side, if there's a problem with the thyroid gland itself, that's primary hypothyroidism. then the pituitary makes more and more TSH, but the gland still fails to make T4. So TSH becomes a signal for primary hypothyroidism. Next. Next slide. So the newborn screen in the United States screens for, in many cases, more than 1,000 metabolic conditions present at birth. That includes TSH. Typically, the infant does not yet show any symptoms, and the goal for any screen is to identify the condition early so that treatment can prevent potential harmful effects. Next slide. So the update for newborn screening is that newborn screen should be performed for TSH on all infants. A second newborn screen is needed at 2 to 4 weeks in newborns who have, similar to the summary on the case, infants who have acute illness and they're admitted to a newborn intensive care unit. They had a transfusion prior to obtaining the newborn screen. They are a monozygotic twin or a same-sex twin. They're a product of an in vitro fertilization, or they have trisomy 21. If they're preterm, to find, in this case, it has less than 32 weeks or low birth weight, a birth weight under 1,500 grams, a repeat newborn screen should be performed at 36 weeks, corrected gestational age. Typically, this is after they are starting to thrive and do better and near hospital discharge. A newborn screen is recommended rather than serum tests because of the lower cost of the newborn screen. And finally, abnormal results should be communicated directly to the primary care provider as soon as possible. Next. Congenital hypothyroidism, as we've discussed, is the most common treatable cause of mental retardation. It can lead to irreversible brain damage or cretinism. Starting therapy in the patient that was just presented as a case will lead to better growth and vigor, but will not reverse the brain damage that's occurred. Prompt therapy in the newborn can minimize the brain injury. Congenital hypothyroidism can be permanent or transient. Most are primary. Central is less common, and most are sporadic, although there are occasional hereditary cases. Next. So here's a young adult that I saw many years ago. His congenital hypothyroidism was missed. Next slide. This is why what we want to avoid by missing congenital hypothyroidism. This is why we have newborn screening. Next. So we'll talk about etiology. So next slide. Most common is primary hypothyroidism, and in general, this is 1 to 2,000 or 3,000. Apparently, from your data, it may be more common in India. Most cases are agenesis or dysgenesis or ectopic. However, inborn error metabolism also occurs in about 20%. The actual incidence of transient hypothyroidism is not clearly defined. The central hypothyroidism occurs in fewer, but it's more like 1 in 16 to 25,000. And TBG does not require treatment, TBG deficiency. Next. So central hypothyroidism generally results from one of 3 causes: a genetic mutation or deletion, as shown here, a midline congenital defect, such as the list here: septo-optic dysplasia, holoprosencephaly, or an acquired birth defect. There's injury at birth, hemorrhage, or hydrocephalus or meningitis. Next. Transient hypothyroidism can result from a number of conditions. So inhibitory antibodies, exposure to goitrogens, iodine deficiency, liver hemangiomas can metabolize T4 too fast, mutations in making T4, prematurity, and illness. So the common factor is that at retest off therapy at age 3 years, TSH is normal. Next slide. The autoimmune causes of transient hypothyroidism are relatively important because if we've seen that mothers can have autoimmune thyroid disease, and autoimmune thyroiditis is seen in about 10 to 15% of mothers. This leads to autoimmune newborn hypothyroidism that adds up to about 2.7% of those identified with newborn congenital hypothyroidism. You can also get transient hypothyroidism from excess antithyroid drug from maternal graves. Next slide. So the symptoms we've seen in the case described: the prolonged jaundice, lethargy, constipation, feeding problems, the skin feels cold. They may have macroglossia, large fontanelles, distended abdomen, hoarse cry, hypotonia, dry skin, and goiter. Next. So this leads up to an infant who might appear to have coarse features like this. Next. But more commonly, babies who have congenital hypothyroidism look like the baby on the left. They have no clinical features of hypothyroidism. We're screening them before they develop features. So there's a wide range of clinical appearance of the infant with congenital hypothyroidism. Next. So here's a typical case. It's a baby boy born at 39 weeks gestational age with a normal birth weight. He's asymptomatic, but the result of his newborn screen is 42. On inquiry, there's a history of maternal hypothyroidism. What's the next step? Next. So in fact, you have to proceed in spite of the history of the mother's hypothyroidism. You need to obtain a confirmatory serum T4 and TSH, consider a thyroid scan or ultrasound, but don't delay starting therapy immediately because the TSH is over 42, start levothyroxine at 50 micrograms daily. If the confirmatory TSH comes back less than 5, you can stop the therapy. In his case, the TSH was 25, so therapy was continued. He was referred to a pediatric endocrinologist to have his T4 and TSH drawn in 2 and 4 weeks to check. If the TSH becomes suppressed, then it's important to decrease the dose to 37.5. If there's a dose change, then the recheck on the T4 and TSH should be done in 4 weeks. And then this baby, because of the maternal history, probably should be reevaluated off therapy at age 3. Next. So to update, you confirm the newborn screen by serum TSH and free T4 or T4 as soon as possible. Consult with a pediatric endocrinologist. If the TSH on the newborn screen is over 40, start therapy while you're waiting for the results. If the newborn screen TSH was elevated but less than 40, you can hold off on therapy till the results come back. On the confirmatory serum sample, if the TSH is over 20, therapy should be started or continued. If the serum TSH is between 5 and 20, you can start therapy or monitor every 1 to 2 weeks with no therapy. Then, if the free T4 becomes low, or if the TSH over 10 persists beyond 4 weeks of age, start therapy. In a baby with trisomy 21, just to note, they should have a recheck on their thyroid levels at 6 and 12 months of age. Next. So we have in the publication that's coming out, we have a new nomogram for decision making. It's difficult to read here, but you can see it in the publication. It's the same as what I just said. Next. Next slide. And update on treatment. We recommend levothyroxine tablets as a treatment. Go back one. That's the treatment of choice. An alternative, can you go back one slide? An alternative is commercial branded oral solution. This is not a compounded oral solution by a pharmacist that's been shown to provide inconsistent concentrations. Also, T3 treatment is not indicated. The dose is 10 to 15 micrograms per kilogram per day. This is 50 micrograms daily in a full-term baby, and provides rapid replacement so that the dose may actually be a little bit too high by a month of age and may need to be reduced. Therapy goals in the first year of life are to get the T4 and free T4 into the upper half of the normal range and to keep the TSH between 0.5 and 2. Next. So update for follow-up is very similar to what was summarized on the case. At 2 to 4 weeks after therapy start, every 1 to 2 months in the first 6 months of life, every 3 to 4 months until age 3 years, and then every 6 to 12 months. The TSH should be repeated in 4 weeks after any change in dose, or if the results are abnormal or if there's suspected non-adherence to the treatment. Next. And to update about assessing permanence of congenital hypothyroidism. CH is permanent if the initial thyroid scan shows an ectopic or absent gland. Also, if the TSH rises to over 10 during the first 3 years due to undertreatment. If there's been no evidence of permanence, babies should be reassessed at 3 years of age at 30 days off treatment. And then if the TSH is over 10, they should resume therapy. They need it. Babies with permanent hypothyroidism need to be treated lifelong. It's critical that the patient not be lost to follow-up during their pause off therapy for reassessment. Next. So we're going to talk about prematurity. Next slide. So in preterm birth, there's loss of the maternal T4 before the typical loss of it in a term baby. There is significant placental transfer of maternal T4 until term. It constitutes about 30% of the total newborn T4. So, and also in preterm or low birth weight infants, the infant thyroid-derived T4 is relatively low at birth. Next. As a result, you can have transient hypothyroxanemia of prematurity from loss of the maternal contribution to the infant's thyroid levels, and also the infant may lack a postnatal surge of TSH. This hypothyroxemia may affect myelination and neuronal migration, and resulting in a loss of 7 to 8 IQ points, also leading to a risk for cerebral palsy. And then after the baby is born premature, the prematurity and illness impair conversion of T4 to active hormone. So even though this may be transient, it may be still that the baby needs treatment. Next slide. So we'll move on to a study that we recently conducted and published in late 2021, so just a couple months ago, in Journal of Pediatrics. So next slide. We were looking at the question of whether the diagnosis of congenital hypothyroidism in very low birth weight is hidden by illness. So we may be missing the diagnosis. The newborn screen was normal in all of these infants except 2. So the total eligible cohort for this study were 644 preterm or low birth weight infants over several years in our single institution. Of that group, 96 of them were severely preterm and died before they were 36 weeks of age. 2 had an abnormal newborn screen. 8 were transferred out to another NICU, and 139 failed to have their second set of thyroid tests done. So we ended up with a cohort of almost 400 infants who underwent retesting before they left the NICU to go home at about 36 weeks corrected gestational age. Of them, the majority had a TSH under 5, but 73, that's 18%, had an elevated TSH. Next slide. So we're going to talk about those infants whose results are shown here in red to orange. How did they differ from the group that had a normal TSH later? Could we have identified them on the newborn screen? So on the left, you can see a comparison of newborn screen TSH across the x-axis for the infants who had a normal and a low free T4. So basically their newborn screens were quite similar. We couldn't have identified them on the newborn screen. On the right, you can see the 2 groups, normal TSH and elevated TSH in the red-orange, and newborn screen TSH value across the x-axis. And there is a slightly higher TSH in the group with high retest TSH later, but you could not differentiate the 2 groups by a single cutoff. Next slide. Next slide. Thank you. So on this figure, we have the free T4 values across the x-axis and the TSH values on the y-axis. This is at the time of retest at 36 weeks, corrected gestational age. And all of those in sector B were essentially normal. They had a normal free T4 and a normal TSH. And then those in sector A had a low free T4, but did not have TSH elevation. So we think those infants might still have been somewhat sick, not fully recovered from being born preterm, or else maybe a few had central hypothyroidism. In C, all of them had elevated TSH and a low free T4. Most likely they had hypothyroidism. And in D, we have those with a normal free T4 but an elevated TSH. Certainly, all of those in groups A, C, and D probably need thyroid hormone follow-up to see what's really going on. Next slide. So on this slide, we compared the newborn screen across the bottom with, so that's newborn screen TSH, with the repeat TSH at 36 weeks corrected gestational age. And remember, all of these babies were considered to have a normal newborn screen TSH by the standard cutoff of 24 or 34, depending on their gestational age. And you can see that no other cutoff would clearly identify all of those with an elevated TSH. So no newborn screen detects all with a high TSH on retest. And each lower newborn screen proposed number would have identified more and more normal babies that would not necessarily need the closer follow-up. Next slide. So in conclusion, at 36 weeks corrected gestational age, 18% of the very low birth weight infants had a high serum TSH. So we recommend that thyroid follow-up is needed in all very low birth weight infants after hospital discharge. Also, lowering the newborn screen cutoff for abnormal TSH doesn't detect most infants who later had an elevated retest TSH. Next slide. So here I've given you some resources that you can use, including our publication in Journal of Pediatrics in November and the upcoming publication that will be in Pediatrics in 2022. And thank you for your attention. I'll be happy to take the question.
Thank you, madam, for that excellent presentation. I think we have few questions in the chat box. Deepa, I think 2 or 3 questions are there in the chat box.
Okay.
Yes.
I think one question is by Dr. Parvati. In India, we do see a definite rise in dyshormonogenesis, especially after newborn screening has been established in our state of Kerala. In your clinical experience, have you noticed that, or still dysgenesis tops your list?
Have I noticed that what was the, have I noticed what?
Hello, sir. Hello.
I didn't hear the last word.
In your clinical experience, have you noticed that still dysgenesis top your list, or after the newborn screening, the incidence of rise of dyshormonogenesis is there?
Well, I think it's perhaps more rare in the United States than in India. Dysgenesis and absent gland are probably more common. When we do have a case of dysgenesis, the thyroid gland is enlarged, so that can be a clue at the time of exam.
Hello, sir. Hello. One question is, I think that is already answered. Is there a certain cutoff in dosage of levothyroxine beyond which the diagnosis of transient congenital hypothyroidism is unlikely to consider at 3 years of age?
Well, if their TSH is normal at 3 years of age off therapy. I personally, I would probably still do another check maybe 6 months later to be sure that it's staying normal, but it's unlikely that the baby's going to continue to have hypothyroidism in view of a normal PSH.
Okay. Do all neonates require 50 microgram at initiation?
No, well, maybe all full-term neonates. So if they're lower birth weight, then you calculate a lower dose. It's relatively easy to get lower doses with the oral solution, pyrosint, approved in the United States. So some physicians are switching to the branded oral solution instead of a tablet.
Thank you. One question is, please comment on long-term effect on body composition of children with congenital hypothyroidism on treatment.
Oh, I'm not sure. I think that if their thyroid doses are kept normal and the TSH is kept normal, the bone marrow composition should be similar to other normal infants. But I don't think I have read the literature for that recently.
Yes. So one interesting question. In the present case discussed, since the child has entered puberty, is there a role for GnRH analog for short term to allow linear growth while the child receives his thyroid hormone replacement?
Yeah, so I don't think that is a standard therapy to do. In a child who's been treated for their hypothyroidism since birth and are now entering puberty, process should be similar to the child. On the other hand, if the child is identified, like the case presented, if adult height is important for that effect case, as he goes on to therapy, his puberty is probably very delayed. Seen that in children who were identified with hypothyroidism at ages 6 to 10 or 11, that once they go on therapies, they may be progressing rapidly through puberty, quite short. So that in that case, a late identified patient, I would use NRH agonist, but not who has been treated all along because their growth pattern is likely to be normal.
Thank you, madam. So that is, I think that is the last question. I think thank you so much for your enlightening talk and the discussion about congenital newborn screening and congenital hypothyroidism, and awaiting for the next 2022 update also, because we are gradually moving towards a screening era of the congenital hypothyroidism in India. Thank you so much, madam.
I'm hoping that every baby in the country will be treated, will be identified.
Thank you so much, madam. Over to Dr. Deepa and madam. Deepa and Shaila, madam.
Yes. Thank you very much, Dr. Susan. I think as Dr. Vijay Kumar said, we will wait for the new guidelines of 2022 and see what are the other changes. But in this case, when there is so much florid hypothyroidism, is there any role of very slow starting of or a small dose of thyroxine? That's one question. And is there any role of starting steroids, hydrocortisone, and then start thyroxine? Because in usually late adolescents and adults, if they have got severe or florid hypothyroidism, they start steroids, even though there is no hypocortisolism. They start steroids so that the child doesn't go into any crisis, and then they will add thyroxine. Is there a similar role in
Yeah.
pediatric practice?
So I'll start with it's kind of a combined question. In hypothyroidism diagnosed in childhood, if it partly the dose to start with depends on the severity of hypothyroidism. So if the TSH is, say, under 50 in a child, I would start with the full dose of levothyroxine. There would be a little adjustment period for the child, but be able to handle it. If it's above 50, then you might start slowly. In general, if their TSH is over 100, I would even take 4 to 6 months to gradually increase. Might start at 1/4 or 1/6 of the eventual dose and not even bother check levels. And so do that for 1 month, then the next month go up to maybe from 25 to 50, and then go up 75, and then get at the end of that month if there's further dosing needed. I have never started steroids with starting thyroid therapy in children. I think that what we want children to do is grow, and steroids would be contraindicated. I think the main difficult part of starting thyroid therapy in a severely hypothyroid child is the effect on their brain. They feel like they're hypothyroid, and it devastate their school performance and family relations. And so starting slowly is really indicated if everybody has to get a chance to adjust the child more and get up and go. And so I would use low thyroid repair and not use steroids.
Thank you.
You're
Thank you
welcome.
very much.
Thank you, madam.
So if we don't have any more questions, Deepa, anything anywhere?
There is one more question, Dr. Sudhara ma'am, from both the experts regarding MCT transporter defect.
That Dr. Andrew has answered in the chat box.
Right, I have shared it with madam.
Yeah. I think there is one
Okay.
question on hypothyroidism. Should we skip morning dose of thyroxine when testing TFT on follow-up?
Should we repeat it,
Should
please?
we skip morning dose of thyroxine when we are doing a thyroid function test when the child is already on treatment and during follow-up?
No, I don't think it's necessary. You don't want to suggest to the parents that it's okay to skip a dose, and you just get the levels. Hi, Andy. So thank you very much for the conference.
Thank you very much.
The interaction, and good meeting you all.
Thank you very much, Dr. Susan and Dr. Andrew.
Great, thanks for the invitation. Hopefully we stay in touch and see each other sometime.
Definitely.
Yes.
COVID behind
Good.
us.
Definitely. Deepa,
Have a good. Stay well. Don't
Yeah,
catch the COVID.
Deepa, vote of thanks.
On behalf of the Indian Society of Pediatric and Adolescent Endocrinology, I express my sincere thanks to our foreign speakers, Dr. Andrew Bower, on enlightening us on Graves' disease in children, and Dr. Susan Rose for the comprehensive talk on congenital hyperthyroidism, the recent update. We thank both of you for the excellent talks and hope to hear more talks from you in the future. I thank moderators for the session, today's session, Dr. Anil Bansali, Professor of Endocrinology, Vijay Chandra, and Dr. Vijay Kumar, Professor and Pediatric Endocrinologist, Government Medical College, Manjeri, for excellently moderating their respective sessions. I sincerely thank both of them for participating in the ACES program in spite of their busy schedules. Especially I'm thanking the case presenters for today, Dr. Sudhir Ranjan from NKCG Medical College, Odisha, and Dr. Rekha from Indira Gandhi Institute of Childhood for the interesting cases presented. I also thank their mentors and respective institutions. I also thank all the institutions which have sent the case abstracts. They were excellent cases, but we had to choose only two of them. I thank our ISPAE office bearers, Dr. Shaila Bhattacharya Madam and Dr. Divya. They are the pillars behind this ACES program. They take so much of trouble into conducting this program and see that it's conducted in an excellent manner. So I express my sincere thanks to both of them for their wholehearted support in organizing this ACES events. I also thank other ISPAE office bearers, Dr. Ganesh, Dr. Rakesh, and Dr. Hari for their support for all towards the organizing this event. It was a wonderful learning experience for me over the past 2 or 3 months organizing the various spaces sessions. Thank you, ma'am, for the opportunity. And today's program has been a huge success after so many after so many sessions with more than 100 participants at one point of time. And I thank each and every one of you for attending and participating in today's session. And especially, I thank Mr. Ankit and Mrs. Neelam from Neelam RX Events for their support and assistance towards conducting this program. Thank you all once again. And thank you for the excellent participation.
Thank you very much. Bye and good night.
Bye.
Good night, stay well.
Thank you, everyone. Bye-bye.
Thank you.
Thank you, everyone.
Thank you.